extrinsic eye muscles. There are those muscles that implement the move of the eye, and we'll see further. And there are vessels. The most important ones are the ophthalmic vessels, vein and artery. And then we have, of course, the optic nerve. And then we have some branches of the trigeminal nerve. So sensitive nerves, frontal nerves, and infraorbital nerve. And then we'll see why it is important to keep in our mind that these structures actually pass through the orbit. As I said before, there are nerves that innerve muscles. Which are these muscles? The extrinsic muscle of the eye are basically 6 muscle plus 1, as I say. So basically 7, but the levator palpebrae is not strictly an eye muscle, because it moves the upper palpebra, the upper lid. So the 4 rectus attach in a cross patterns, and the 2 oblique muscles. Then we go to see very quickly the zygomatic bone. It has a pyramid-shaped, approximate pyramid shape, and with 3 buttresses: the nasal buttress, the frontal buttress, and the maxillar buttress. And there is this foramen. Through this foramen passes the infraorbital nerve, that, if you remember from the previous picture, it's a branch of the second branch of the trigeminal nerve. So it's sensitive and innervates all the middle third of the face. As said before, the zygomatic bone has these 3 buttresses, which means 3 sutures. If we have to refer to the principles, and you remember, the sutures are place of energy dissipation. So those are the one to break. When we talk about the zygomatic bone fracture, a full zygomatic bone fracture is also called tripod fracture, because it has 3 rims. It always has 3 rims, unless it's not complete, of course. And this is important when we will talk about the treatment of the fracture, because there is this rim, which is very posterior on the arch, which is very hard to access. But since the shape of the bone is tripod, and we have these 3 sutures, it's usually important to fix or to check the position of 2 sutures to give for granted that the third one will go on its place. Talking about epidemiology, it's a pretty high incidence. So when we talk about the facial fractures, the higher incidence are the mandible and the zygomatic orbital areas. So we say it's about 30–40% of the incidence of facial fractures, and it mostly caused by road accident or sport accident or assaults. Even in this case, it's rarely work-related. At a physical examination, it depends. It can vary a lot. A lot depends on the overlying edema that can be present. So we usually note a facial asymmetry, but these ones sometimes can be masked by the overlying edema. So we usually have a facial width increase and a cheek flattening. We have a periorbital ecchymosis. We could have crepitus. As I said before, crepitus is a sign of subcutaneous emphysema, so the presence of air in the subcutaneous tissues, meaning that the air, which is usually contained into the sinuses, has somehow come out from the sinuses. And we have V2 numbness. So numbness of the second branch of the trigeminal nerve. If you remember from anatomy, the trigeminal nerve passes on the floor of the orbit and comes out from the zygomatic foramen, approximately in an area around here. So basically where the hematoma is in this patient. We could have lateral canthal dystopia, so the displacement of the lateral canthus of the eye, which is this area here. We could have trismus, but trismus is not really correct. So we could have limitation of the movement of the mandible for two reasons. One is trismus, so it's a trauma, a direct trauma or an indirect trauma on the temporal muscle, which is an elevator of the mandible, or sometimes it could be due to an impingement of the coronoid under the zygomatic arch. Of course, there might coexist signs of orbital or globe injury, depending on the kind of trauma. The diagnosis is mostly done through CT scan, and it's very important to keep into consideration at least two cuts. The two most important cuts are, of course, the axial cut, which will show us if there is a changing in the anteroposterior position of the zygomatic bone, and the coronal cut. The coronal cut will give us indication on the state of the orbital floor, because the orbital floor, being a transverse structure, can be hardly checked from an axial view. And the lateral view or sagittal view is it's of help, but it's not mandatory. What we need to assess for displacement of the fracture and for the presence of comminution. And I would also add how many buttresses are involved. But usually when there is a lot of displacement, all three buttresses are involved in the fracture. And as I said before, we have to assess the state of the orbital floor, because this is a game changer. So this one is I think that would change our surgical approach, and I'll tell you why. The management is, as you have understood, guided by the CT imaging, and so we have to check for the amount of displacement, amount of comminution, the status of adjacent buttresses, including the naso-orbito-ethmoidal structures, and the state of orbital floor. And once we have assessed this, we have to decide how many buttresses we have to expose. So how many fixation points we need. And this is all done through the analysis of the CT scan. Of course, the more complex the fracture is, the more buttresses we will need to expose, the more points of fixation we will need to have. So it's basically dictated, everything is basically dictated by comminution and severity, which is assessed through the CT scan. And the orbital floor needs to be assessed if there is an herniation. If we see an herniation of the content of the orbit, so if we see there is a complex orbital floor fracture, we go and check it once we have already fixed the zygomatic fracture. So in case we have a consistency between a zygomatic fracture and an orbital fracture, first we fix the zygomatic fracture, and then we go for the orbital floor. So first the frame, then the content. And then we have to decide how many points of fixation we need. So a single point of fixation for a not very severely comminuted or displaced fracture might be enough. And this is depending on the school you're from. Single point of fixation from many schools is the frontal buttress. So this part, the upper part. For some other school, which is what I personally do, when I choose a single point of fixation, I choose the lower part of the zygomatic bone. I'll tell you why. It allows you for a very good view because you cut intraorally, you open up and you see clearly everything, and you can even check the infraorbital nerve from down to top. And it very easily enables you to assess if there are vertical problems in the fracture, and it basically leaves no scar because everything is performed through the mouth. And this is what, for example, AOCMF, for those who know what I'm talking about, is saying. AOCMF is a very important foundation which basically carries out a lot of researches in the generally bone trauma. It was born as an orthopedic foundation, but it has now begun as well for craniomaxillofacial. Then it's 2-point fixation. Again, it changes from school to school. So usually the second point of fixation should be the infraorbital one. And the 3-point of fixation, frontal, infraorbital, and intraoral fixation. So we fix all 3 buttresses. And as I said, the order of the fixation may vary from school to school. And the 4th point of fixation, which is not reported here, is the fixation at the level of the zygomatic arch. But this is really rarely performed, and it's just for very, very complex fractures. And we have talked about the fixation. We have to talk about the incisions, because if we have to fix a bone buttress, then we have to access it somehow. There are basically 4 ways to access the zygomatic bone, and each one allows us to address and to access a different part of the zygomatic orbital complex. The coronal one is probably the best one in a matter of how much we can expose, but of course it's very heavy for the patient. It leaves a lot of scar, so it's rarely carried out just for very complex fractures. Usually when a fracture is also associated with a frontal fracture or neurocranium fractures. And the routinely used ones are these 3. So upper eyelid will help us to expose, I will show you later on, the frontal zygomatic area, the lower eyelid, and the vestibular cut, which will help us to address the lower part of the zygomatic bone. And of course, if there is any, we will just go for existing laceration. So the upper eyelid incisions can be done in several fashions. The most common one are the external third of the eyebrow, or as a skin crease, so inside the palpebral crease. What will happen, it will help us to, I can't see this part of the screen, but it will help. You will see on the right part of the screen, you can see which part of the zygomatic bone these incisions allow us to access. It's basically the lateral wall, the anterior aspect of the lateral wall, and the frontal zygomatic suture or buttress, if you like. The lower eyelid incisions, also in this case, there are several ways to perform it and several variables, and it's really up to the surgeon, but it's done to expose the infraorbital rim, part of the zygomatic body, and the orbital floor. So the main reason to make this cut, to me, is the need to address the zygomatic floor. There are schools in which this one is the first cut to be made. I don't agree, but it's just a personal feeling. So this would be the last I do. There is one very good incision, which it's basically superimposable as a part of that will let us expose, which is the transconjunctival incision. The transconjunctival incision is, as you can see here from the lower picture, it goes directly to the bone. There is basically no structure in between the conjunctival sulcus and the bone. It will help us to expose. Basically, if it's done just a transconjunctival incision, it will just help us to explorate and expose the anterior aspect of the orbital floor. But this can be extended medially as it's so-called retrocaruncular incision. This incision is very good to expose the medial wall of the orbit. Or it can be extended laterally with a cantotomy. This would give us more space. It would help us to explore basically the whole orbital floor and the orbital rim. So the transconjunctival incisions extended with this lateral cantotomy, it allows for the same area of exposure of this traditional one. but it requires a little bit of, it's not hard, but it requires a little bit of more confidence because it's not very comfortable for the surgeon to do it. And then we have the vestibular cut. The vestibular cut is usually done 5 millimeters above the attached gingiva, because otherwise it's very hard to perform the closure correctly. And it allows us to see all the inferior aspect of the zygomatic bone and the more anterior aspect of the zygomatic arch, just a tiny bit though. Let me show you some cases. This is a patient of left zygomatic fracture. As you can see, if you remember the flow chart, we have flattening of the cheek with a little bit of widening of the face, that you can see maybe better in the bottom to top picture. In this case, we have decided for a 3-point fixation. So here you see the infraorbital incision with a very comminuted fracture and a load sharing mini plate. This one is an incision through the upper vestibular sulcus with addressing the lower part of the zygomatic bone with another load sharing fixation. Why do we use load sharing for the midface? Simply because there are not many muscles attached to it, so there is not a lot of load to be bared. And this is how we treat, it's a way to treat the orbital floor fracture. The orbital floor fracture cannot usually be sensitized, so it cannot be fixed with Palladian screw. So what we do is to reconstruct the orbital floor. We usually reconstruct it with biomaterials, or sometimes if it's severely comminuted, we might use titanium mesh. I personally try to avoid titanium mesh as much as possible, but sometimes you just can't. Because the fact with titanium mesh is that if there is another trauma in the future, that floor will not break, so the eye would break. That's the problem. So it's always a concern. And this is the patient after the treatment. As you can see, there is a regain of volume in the orbital, in the zygomatic area. So the malar area has regained. So it looks almost better than the one which was not broken. Second case, another guy. This was a car accident. This is the CT scan. It is a very, very displaced fracture, not particularly comminuted, and I expect it to be the floor to be broken, and that's the case. Actually, the fracture is pretty big, as you can see here from the picture. So as I told you before, what do we do? First the frame, then the content. So first we fix the zygomatic bone, then we go inside and we check for orbital floor fracture, and we go and reconstruct the floor. This is the CT scan before and after. And this is the patient before and after. This is the main reason why I don't like subpalpebral incisions. They actually, it has to be said, in most of the cases, they heal pretty well. If the patient takes care of the scar, there's usually little or no scar. This picture was probably taken after a few weeks after the operation, but there is also a risk of leaving a scar, and there is always a risk of a drowsy lower lid. This is the patient before and after. As you can see, the clinic shows us again a flattened zygomatic area which has regained volume after the treatment. Now we go to see isolated orbital floor fracture. So we have already seen the orbital floor fracture in association with a zygomatic fracture, but it can also be isolated, and it's actually quite a frequent possibility. What do we define as a isolated orbital floor fracture? The margins are usually not involved and there is a usually a blowing on the floor. That's why it's mostly called blowout. It has to be said that nowadays every orbital floor fracture is called blowout, but it's not really correct. Then we'll see which other floor fracture exists. And it's always an indirect fracture. So the force does not insist directly on the bone, but insists on another structure which actually does the fracture. And this structure is the eye. And a typical example is the tennis ball that hits the eye. The eye retains a certain degree of elasticity, and so it's deformed by the trauma, and its vertical dimension increase, and with this increase, the eye break the orbital floor. But this is another defense mechanism, because otherwise the eye would explode. So the chances of the eye to explode would be higher. And that's also the reason why I was telling you that I'd rather not use a titanium sheet on this part, because if another trauma like this should happen to the patient, there wouldn't be this possibility to save the eye. About the causes, mostly sport accident and accidental fall or assault. That's a very common situation, is the punch in the face and blowout fracture. The clinical diagnosis usually shows us a periocular edema and a scleral hemorrhage or chemosis. What does chemosis mean? Basically red eye. We could have ocular asymmetry, epistaxis due to the bleeding in the nasal sinuses, and ocular movements limitation. But then there are a couple of subjective symptoms. So there are a couple of things that the patient could tell us, but we don't see. So it's diplopia, so the double vision, and sensitivity alteration of the trigeminal branch. Why this is happening? Alterations of the trigeminal nerve. We have seen the anatomy before. The trigeminal nerve passes right on the orbital floor in a small bony canal, and if it breaks, it could suffer. And the patient tells they have anesthesia in the mid-face or dysaesthesia, depends on the entity of the fracture. And diplopia, as I said before, is a double vision. Diplopia can depend on two major causes. The most common cause is edema. So there is edema at the level of the orbital floor. The edema pushes the eye globe a little bit up, and so the two globes are not aligned anymore. And this is a situation that most of the time just goes away on its own, and sometimes it's present even right after treatment. So the patient has diplopia before and after. In the most actually worrying situation is the second one, so is the incarceration of the lower rectus. If you remember the 6 extraocular muscles, the 3 rectus muscles shaped in a cross, the lower one lies right on the orbital floor, and sometimes it can get trapped into the fracture. The trapping of this muscle into the fracture would block the eye from move. So the patient will be only able to move one of the two eye. So the two eye will look into different position, and this look in a different position will create a double vision. And this is a situation that has to be addressed with a high priority. About the radiological exam, CT scan again. As I said before, the zygomatic fracture, we needed a coronal view in order to assess the orbital floor, and there is no difference for this kind of fracture. So the most important cut for us in a CT scan is the coronal cut. The coronal cut could show us a discontinuity in the bone and the herniation of the intraorbital content. In the former type, the mostly used plain radiograph for this was occipital-buccal. That is the only way we could actually see and deproject the orbital flow from the other structures. So there is a question that could arise: is wouldn't the frontal be better? On a theoretical basis, yes, but on the frontal view, there are too many structures covering one another. So in a plain radiograph, this happens really often. It happens probably like in a dental school. You do oral X-ray, don't you? Hello?
Yes.
Yeah, you do. And how many times do you have to repeat intraoral X-ray because it's not clear? So a few times. So you have to check how to put the tube, right? And so it's not always straightforward. And the plain radiograph for the head and neck district doesn't make any difference. So the problem is that with the frontal view, there are too many structures, you wouldn't see anything. So the occipital-buccal was the projection of choice. I think it's always important to know there are other options but CT scan. So again, what do we see from CT scan? Discontinuity of the bone, herniation of the intraorbital content, presence of blood, so-called hemosinus, in the nasal cavity, and we see the muscles, and we see the nerve. This is the muscle we are concerned about, the inferior rectus, and this is the one that can get trapped into the fracture if the fracture is of a certain type. Then we'll see. There is another radiological exam that can be performed for orbital fracture or generally for fracture is the MRI. But MRI doesn't give us many information about the bony tissues. It's more an exam which is done to assess the state of the soft tissues. So in case we have any doubt of any internal damage on the structures of the orbit or on the eyeball, we might choose to do an MRI, but this is definitely not a routine exam. What is also highly recommended is to have a check with the ophthalmologist, mostly to assess diplopia. So as I said before, diplopia is a symptom, it's not a sign. So there is, we can't see diplopia, but are we sure? No, there is an examination that actually makes us see diplopia, and it's called Hess chart. The Hess chart is basically a screen which the patient has to fix with his eye, and there is a light moving. And the patient has to say to the operator how many light he sees. Of course, there is just one light. So whenever the patient sees two lights, is signed on the screen, and the position of the point define the position of the eye. So we can actually objectivate the entity and the position of the diplopia. And then there is another check that we could do. We personally, in our department, we don't do it preoperatively because it's not nice for the patient, but it's a forced traction test. The forced traction test basically consists of pinching under local anesthesia, pinching the insertion of the inferior rectus in the eye and pulling it onward to check if there is entrapment of the muscles. We personally don't do it as a preoperatively assessment, but we do it intraoperatively at the end of the procedure in order to check if there is any residual entrapment of the muscle. So we do it when the patient is asleep, because it's not very nice to have, force it inside your eyes, even if it's under local anesthesia. What do we do for orbital fracture? As I said before, we mostly use biomaterial. So we put a sheet, which is resorbable, to cover the fracture. But we can also go for titanium mesh if the fracture is quite extended. And this is how the mesh is put. The mesh, of course, has to be fixed with screws, at least one screw. I would go for two, because otherwise there is a risk of displacement, and the risk of displacement of a titanium sheet is not a nice thing. While usually for biomaterials, we usually don't put any kind of fixation, because the pressure inside the orbit itself is usually enough to keep it in place. Let's go, we'll see another patient. This is how he was preoperatively. So here you see entrapment of the inferior rectus. So as you can see, we asked the patient to look up. He looks up with the eye, with the uninvolved eye. He is not able to look up with the fractured eyes. This is the chemosis I was talking to you before, so red eye. Of course, in this case, there is also an important exophthalmos. This was quite a big fracture. And this is the patient after a couple of weeks from the operation. Another patient. Again, as you can see, the patient is looking up because we asked him to do so, but the left eye is just looking straight in front of us, showing us that there is incarceration of the lower rectus. Another thing that we notice is the so-called pseudoptosis. So the upper lid, it's actually far down compared to the other one, but it's not due to a problem and function of the lid. It's due to a problem of position of the eye, so an enophthalmos, which means that the eye goes back, goes behind compared to the pre-traumatic position, and this basically leaves more space to the upper lid to go down. This is not really an isolated fracture, so it's an orbital rim plus orbital floor fracture. This is how we do. First the rim, and then, of course, in this case, I would have probably also gone for a titanium sheet. Now we go and see the isolated arc fracture. The isolated arc fracture is a relatively common situation, and it's mostly caused by sport accident or assault, but it's very common in sport accident. The typical example is the hit of a knee bow during a soccer match. This is the most common cause of isolated fracture for what's my experience. The force is it's a direct fracture, so meaning that the force insists directly on the fracture, and it's from lateral to internal. It's usually V-shaped. Sometimes it can be more comminuted or more complex, but this is definitely the most common situation that we might encounter. In this case, there might be mandibular movement limitation to impingement of the coronoid process under the zygomatic arch. Because if we remember from anatomy, the coronoid process of the mandible goes, when we stay with our mouth closed, the coronoid process is medially from the structure. And when this structure collapses, basically pushes on the coronoid process, preventing the mouth to open or to close, depending on how the patient was at the time of the trauma. This was, of course, the diagnosis is, again, boring CT scan. And this was the only indication of the attenuated axial projection in a plane radiograph. If you can see in this CT scan picture, you see this tiny white point. This tiny white point is the coronoid process. So can you see how close the relationship is?
Yes, it's visible.
This is one of the fracture I was mentioned before, where there is a surgical procedure with no fixation. So we don't do a direct exposure unless it's very, very comminuted, or unless we have a pre-existing laceration. We go for reduction. but with no fixation, because usually the two fragments, they collide very well and they basically fix themselves one another. What we do is intraoral approach. So we do a tiny cut, 1 centimeter approximately of length at the level of the sixth element, the second molar. We just do a cut through the mucosa and submucosal layer, and then we go directly with an elevator. So we don't even do dissection. So we just go directly with the elevator. We pushed it under the arch. You can easily feel it with your hands when you're under. And then we apply the force in order to reposition the arch. And this is another technique. I couldn't find any picture from our department because we don't do it. So I Googled it and I found this one. It's the extraoral approach. The extraoral approach requires a cut in the skin, or sometimes it's right at the beginning of the hairline. You go on the subcutaneous tissue, you get on the temporalis muscle fascia, you go on the deep temporalis muscle fascia, and then you insert the elevator. This procedure, compared to the other one, has a different charts of problems. First of all, scar. Second of all, you're always putting, somehow degloving a muscle, which is the temporalis muscle, which is not a very good thing to do. And there is always the frontal branch of the fascial nerve, which is lying here. So why would you bother with such a thing when you can easily go with no damage from the inside? So this is surgeons that actually prefer this, because in this case, of course, you can control your instrument better because it lies just under the skin and you can feel the whole instrument. From the oral aspect, of course, you just go inside and it's already so deep you can't really feel. You just can feel the top of the instrument when it goes up over the arch, but that's all. So in this case, you can better control the instrument, but in the other case, there is virtually no damage that you could do. Then we go to the pediatric management. I would like to make a little introduction so that our department doesn't treat so many children, because Rome has a big hub, which is called Bambin Gesù Hospital, which is a children's hospital. So 95% of the trauma children trauma are managed there. We have a few, but I would like to give you an idea of how the children traumas management work, because it's not quite the same as adults. I would like to start with this phrase that children are not small adults, so they cannot be treated such as small adults. So they have some specific features and then have some specific needs that do not match with adults at all. So as you remember from the initial part, the orbit and the zygomatic area is made up of 7 different bones: frontal, maxilla, zygoma, ethmoid bone, lacrimal, and lesser and greater wings of the sphenoid, and a little part of the palatine. These bones, they retain a different extent of different quantity of rigidity and fragility. And this is actually different in children, where the bones are not completely mineralized, so they are absolutely not with the same rigidity or strength of the adult bone. They retain far more elasticity, and this can be a good thing and this can be a bad thing, and we'll see why I'm saying that. Another thing is that as we saw from the anatomy, there are parts of the orbit that are in contact with the sinuses, and the sinuses are very important mean of the defense for eventual damages. Children, they have hypo-developed or undeveloped paranasal sinuses, because the paranasal sinus system develops from the approximately 3 years of